Hello, and thank you everybody for joining our webinar today. My name is Tom Biggerstaff. I'm the product specialist here at GORE for our Cardioform ASD Occluder. Today I am joined with Dr. Qureshi from Texas Children's, and we're excited to bring you this educational webinar about the Cardioform ASD Occluder. Before we get into the presentation itself today, we just wanted to talk about a few quick items. So all participants in the webinar will be muted with exception to the presenter. But if you do have questions throughout the course of the presentation, there is a tab at the bottom of your screen that you'll see called Q&A. You can submit any of your questions there throughout the presentation. And we have time allotted at the end to address any of those questions that you may have. So we'll make sure that we have sufficient time at the end to address those questions. We'll go ahead and start with the presentation. So I want to go ahead and introduce Dr. Qureshi from Texas Children's Hospital. He's here with us today. We're extremely thankful for him being here. I know he's faced a lot of challenges recently there in Houston, where he's based out of. So we really want to thank you, Dr. Qureshi, for hanging in there and joining us today to help educate on the Cardioform ASD Occluder device. And with that, I'll hand it to you.
Well, thank you, Tom and Alex, for the well wishes, and to everybody at GORE for the opportunity to present today. I'd specifically like to thank Alex Cochonel and Tom Biggerstaff, and again, everybody from GORE for allowing me to present today. So today I'll be talking about the GORE Cardioform ASD Occluder, and we'll be going over device features, benefits, and really some basics of the procedure. These are my disclosures. The relevant one is that I'm a consultant for W.L. Gore and Associates and a proctor. So the way that I have outlined this talk today is to first go over a brief overview of the device and go over some historical comparisons of the device with previous generation of GORE devices. I'll then go over some relevant recent trial data, specifically the pivotal trial. Then we'll go over some relevant anatomy, the correlation with imaging, and specifically I'll go over some case illustrations. And this is meant to be a basic webinar, so we'll be going over basic cases today and really illustrating a step-by-step approach to deployment of the GORE Cardioform ASD Occluder device. I'll also talk a little bit about how the device can be retrieved, both with the retrieval cord and without it in the rare instance of a device embolization. And then we'll also talk about wireframe fractures, which can occur, but fortunately have not resulted in any clinical sequelae to date. So this is the GORE Helix Septal Occluder, and this image I've taken from a publication from Dr. Tom Jones in the Journal of American College of Cardiology in 2007. And so this was the first generation of GORE devices. And in this study, about 120 patients who underwent implantation of the GORE Helix Septal Occluder were compared to those who underwent surgical closure. So it was a really nice study comparing surgery to device closure using the Helix Septal Occluder. And what they found was that device closure with the Helix Septal Occluder was safe and efficacious when compared to surgical ASD closure. So a really nice study. You can see here the Helix was consisted of one long wire frame consisting of nitinol, and the device was made out of EPTFE. There were steps involved, which included, many of you may remember, I've heard of the push, pinch, pull sequence, where by pushing the device out and then pinching and pulling on the mandrel, you could actually conform each of these leaflets in a sequential fashion. So this was available up into a size of 35 millimeters. The next generation was the GORE Cardioform Septal Occluder, which is still available, a very nice device. This is available up to sizes in 30 millimeters. And this consisted of a handle and a slider, which really perform much of the steps for the operator. While you push out the slider, you are able actually to conform the left and right atrial side of the device. The device consists of 3 islets: the left atrial islet, center islet, and right atrial islet. And the advantage of this device over the previous generation Helix device was its enhanced visibility, but also the deliverability is easier of the device, and also it's constructed of 5 nitinol wires, if you will, allowing for a little bit more rigidity and stability of the device. So I'm just going to talk a little bit about the GORE Assured clinical study using the GORE CardioForm ASD Occluder device. So in this study, this is just a snapshot showing that there was a 100% closure success rate at 6 months. And closure success rate was defined as a clinical residual status of either completely occluded, or if there was a small leak, it was clinically insignificant. And this was determined by the Echo Core Lab at the 6 months evaluation period. There was a low rate of 30-day serious adverse events, low rate of clinically significant new arrhythmias, and a low rate of device events, which were defined as post-procedure device embolization, device removal, or any other device reintervention from completion of the implant procedure through 6 months. The pivotal study, there were involved enrollment of 125 patients, and the objective of the study was to demonstrate that percutaneous closure of ostium secundum ASDs with the GORE CardioForm ASD Occluder is safe and effective. This was a prospective study. It was a multicenter single-arm study compared to performance goals derived from clinical study outcomes for devices indicated for ASD closure. There were 2 training cases required for each site prior to enrolling pivotal studies. There were no age limitations in the study, so this was a study which involved both pediatric and adult patients. And inclusion criteria included patients who had ASDs measuring 8 to 35 millimeter by the stop flow technique. There were no retroaortic rim requirements, so if you had a deficient aortic rim, you could still be eligible to undergo implantation of this device. Eventually, a 3-year follow-up is anticipated. There were 22 sites in the US who participated in this study. The GORE CardioForm ASD Occluder, this is the newest generation of the GORE ASD devices. It consists of an anatomically adaptable waist which fills and conforms to the defect. So this is something new. Notice that there, and I'll show you some other images, there's no center eyelet. The waist is adaptable and conforms to a wide range of device sizes. It's very soft and conformable, and it's designed to integrate with the natural structure of the atrial septum. And of course, the design has and material properties are very nice in that it allows for a soft device to be implanted, yet at the same time it conforms to the septum. And based on which device is used, there are 5 to 8 wireframes in the device. These are the sizes for the GORE CardioForm ASD Occluder. The smallest size device is 27 millimeters. And the largest size device available is 48 millimeters. The catheter size required, the sheet size required for delivery, you can see there ranges from 10 French with the smallest device, the 27 millimeter device, to 14 French with the 48 millimeter device. And what you'll notice here is the treatment range is quite broad, as you can see here. And this is where the use of that anatomically adaptable waist really comes into play, where there is overlap between sizes. And the operators can choose on a number of different devices based on the overall geometry of the ASD and the surrounding atrial septum. Again, this is the device chart that one should be familiar with, and it really expands our options going all the way up to 48 millimeters that in some instances can close defects as large as 35 millimeters. So this is just a video that I'm going to go over. This is a video depicting deployment of the GORE CardioForm ASD Occluder. This is the handle. You see the slider there going in motion. And once you push it out, this is the left atrial side of the device being released. And then you see the waist being formed, and then the right atrial side of the device with the control catheter. This is just another depiction of that in a beating heart video cartoon, if you will. You can see here that in this instance, the device is crossed with a wire. Again, you would require 2 Frenches larger if you are going to go over a wire. The wire is removed. The left atrial side of the device is deployed. You can see this cone-shaped device. So it's different from the GORE Cardioform Septal Occluder device. There is no center eyelet. And then you can see here the right atrial side is being deployed. The device can then be locked by pulling back on the slider. And then the retrieval cord, which is similar to that with the GORE Septal Occluder device, is removed and the device is then left in place. So the inclusion criteria were any patient who had secundum ASDs measuring between 8 to 35 millimeters by stop flow technique. You had to have obviously evidence of hemodynamic significance of the ASD. Vasculature had to be appropriate, adequate septal rims, and of course accommodation for TEE or ICE during the procedure. Multiple defects requiring more than one device. I won't go over all the exclusion criteria for the sake of time, but of note that I want you to note that multiple defects requiring more than one device were actually excluded from this trial. However, if you could implant one device that could close multiple defects, that would meet inclusion criteria. These were the primary endpoints. The co-primary endpoint 1 was 6-month closure success, and this just was defined as clinical residual defect status of either completely occluded or clinically insignificant, again, determined by the Echo Core Lab at 6 months evaluation. The co-primary endpoint 2 was composite clinical success, evaluated at 6 months, and this consisted of technical success, safety success, and closure success. Secondary endpoints were also looked at in this study: technical success, procedural success, long-term composite clinical success, long-term closure success, and safety outcomes in addition to clinically significant new arrhythmias. So there were 125 patients enrolled in the study. The first training and pivotal subject enrolled was in March of 2017. And the last pivotal subject completed 6-month evaluation in May of 2018. The continue access phase is now stopped, but a large amount of additional patients were enrolled in the continued access study as well. The analysis was locked in July of 2018, and the data was presented in September of 2018 at the PIC Symposium. The data was submitted to the FDA in November of 2018, and we were all very glad to hear that the FDA approved the device in May of 2019. These are the baseline characteristics of the procedure, of the patients undergoing the procedure. You can see there that about 72% patients were less than 18 years of age, but there were a number of adults in this study. The average weight of the procedure was 45.1, ranging from 12 kilos to 105 kilos. And ASD sizes were quite large in this study. The mean was 14.5 millimeters, ranging from 6 to 36 millimeters in size. And the stop flow defect size, you can see there, correlated with that ASD size. The mean stop flow diameter was 17.3, and multiple fenestrations or defects were present in 14% of patients. A small number of patients had atrioseptal aneurysms. Most of the devices implanted were the 32 millimeter devices, but you can see there were devices implanting ranging from 27 to 48 in all categories, essentially. A number of patients underwent implantation of the 44 millimeter device, about 1/5 of the cohort, and 4% of patients underwent implantation of a 48 millimeter device. So when we looked at the co-primary endpoint 1, out of 125 of the patients enrolled, 112 completed the required assessments for closure success. So these were patients who underwent technically successful closure. You could see there that there was a 100% closure success rate at 6 months. And this was regardless of whether there was deficient retroaortic rim. The composite clinical success, as defined by satisfying the achievement of not just a closure success, but technical success and safety success, was 90%, or 108 out of 120 patients at 6 months follow-up. There was a high technical and procedure success rate. Again, you can see the technical success rate was 96% and procedural success rate of 96% as well. And the study demonstrated that there was a low rate of 30-day serious adverse events, which was 4.8%. And this was again also seen as a low rate of device events through 6 months of 2.4%. And only 4.8% had a clinically significant new arrhythmia. All of these were eventually able to be treated. These are just some of the 30-day serious adverse events that were seen. Supraventricular tachycardia, there was 1 CVA, device embolization in 1 patient, fever, atrial fibrillation, and migraine with aura. When we looked at the 6-month device events, secondary endpoints, there was a low rate of device events through 6 months. Only 1 patient had SVT, and that was with a 44 millimeter device in a patient who had a defect size of 23 millimeters. Again, there was a low rate of clinically significant arrhythmia, and these were in patients who had no history of prior arrhythmias. And these were any new arrhythmias documented on ECG requiring hospitalization, initiation of new long-term medical therapy, or post-index procedure cardioversion or intervention. And when we looked at what are the risk factors for clinically significant arrhythmias, you can see that here that if the patient was more than 18 years of age, then that was significant. Also, what was noted was device sizes. 44 and 48 millimeter devices were associated with clinically significant new arrhythmias, as was whether a device was oversized. These are the study sites who participated in the study, and this study was, again, a very successful study led by Dr. Matt Gillespie and Bob Summer, and all these sites who participated. Thank you to all of them. So now I want to go over some clinical applications of the GORE CardioForm ASD Occluder device. And you can see here, this is a cartoon that was made by one of our fellows, and this publication is in process, and describing the anatomy that one must be familiar with when closing secundum ASDs. And defining the rims and knowing where the rims are very important. You can see here, this is the bicable view looking at the superior and inferior rims by TEE. You can see the short axis view looking at the anterior superior rim and posterior inferior rim. And again, sweeps are very important. And again, the posterior superior rim in the 4-chamber view and the AV valve rim, or the anterior inferior, some people call that rim. So there are various terms that have been used, but it's important to understand the anatomy and get a good assessment via sweeps on a TEE or intracardiac echo when one is performing these procedures. So I'm going to go over a few case illustrations at this point. And this is a very straightforward ASD. They often don't come like this straightforward, but I just want to show this case to depict how the device is used. So this is a 4-year-old with a central secundum ASD. This patient had Down syndrome. He was 20 kilograms, and the stop flow diameter of the defect was 11 millimeters. His QPQS was significant. You can see there 1.8:1. So this is his TE at baseline. You can see there that it's a very nice central defect. There are very good rims, good margins in the views that are shown here. This is stop flow with a balloon using the stop flow technique, measuring the diameter that was, again, 11 millimeters. And here is the device being deployed. You can see here, this is an LAO-cranial projection on the AP camera on the left of the screen. And on the right of the screen is a straight lateral projection. And you can see here the device is being deployed. This is the left atrial side of the device being deployed. And so it's different from the GORE Septal Occluder device. You can see there's a left atrial islet, there's a right atrial islet, and there's really the central waist. And you get a sense of the what the central waist looks like once you deploy the left atrial side. It looks like a tulip, some have described it as, or a cone. Some have described it as looking like a cone. And so then that is pulled back. Once you get it into position, you can see there that it's pulled back towards the ASD. And this is, again, with TE guidance in this particular case. And then once you see that left atrial side of the device being deployed, you can feel on the handle where the waist of the device has been met. And the device is then deployed by pushing out the right atrial side using the slider on the handle. Now, sometimes you may have to apply, in fact, more often than not, a little bit of tension just so you have that left atrial side of the device abutting the atrial septum. Not a lot of tension, you don't want it to pull through, but you do want to have enough tension that it allows you to deploy the right atrial side of the device on the proper side of the atrial septum. And again, you can see here, this is the locking of the device similar to the GORE Septal Occluder. Once the device is locked by pulling back on the slider, you can see there's a shift in the device. This is not uncommon. Many times, more often than not, I should say, there's a lot of tension on these devices. So once the device is locked, you'll see it's more natural configuration against the atrial septum. Now, this is just a TEE image showing what the device is going to look like when it is locked. And for those of you who have not used the GORE Septal Occluder or this device for that matter, this is going to take some getting used to. And if you are happy that you have grabbed the rims, then it is okay to go ahead and lock this device, because more often than not, when you lock it, it's going to assume a more natural position. You may see some shunts before you lock the device, and that's okay. The most important thing is to make sure that you've grabbed the rims. And you can see here that even though this looks slightly perpendicular to that SVC rim, we were confident in this case that it had grabbed the rim. And you can see here, once the device is locked, the left atrial side of the device and the right atrial side of the device are parallel to the atrial septum. So definitely, for those of you not familiar with these devices, it will take some getting used to. Even if you are familiar, for your echo colleagues, it's going to take a little longer to get used to. So it's very important to, I would recommend going over these images and demonstrating this with your echo colleagues prior to embarking on these procedures. This is just a fluoroscopic example of that same patient. I like to get the arrhythmias view. It shows the device on FOSS with the pins aligned with each other. This is also a good view to assess for any device fractures and follow-up. And the lateral projection is very important, particularly with the GORE Cardioform ASD Occluder. You want to get a nice LAO-cranial projection on the lateral. Now, if you're using single plane, then the whole procedure can be done, but I would recommend you use steep LAO-cranial projection just to make sure you have good separation of the device. You can see here the anterior superior rim and posterior inferior. This is a really nice example showing how the device should be splayed and look like have this sort of butterfly configuration. So you really want to see that splay both in the anterior superior area and posterior inferior. And oftentimes you may think that you've captured the rims by TEE or ICE, but every now and then you may notice on your fluoroscopic imaging that that's not the case. So really important tool to fluoroscopic imaging is really an important tool in the assessment of the device. This is what the device looks like after locking. You can see, again, it's not uncommon to see some flow between the discs of the device. There's trivial flow here, but that almost always resolves. And then after assessment, the cord was completely removed. Now, what about patients who have slightly more challenging anatomy? So again, I'm demonstrating illustrating cases in children, but again, this device is approved for adults as well, and I can show you some examples of that also towards the end of the presentation. But this is a 4-year-old with a secundum ASD who had a deficient aortic rim. So these defects can be challenging. This patient had a moderate-sized secundum ASD with right heart enlargement. The patient weighed 21 kilograms. The stop flow diameter was 16 to 18 millimeters, depending on the fluoroscopic and TEE image. And the QPQS was quite significant in this patient. This patient had a QPDQS of 2.4:1. This is the transthoracic echocardiogram at baseline. You can see there that it's a sizable defect for a 4-year-old, and which you'll also note that there's a deficient aortic valve rim there. You can see that the right heart is quite enlarged. And I often look at the right heart in these patients, and it gives me an idea of how challenging these ASDs may be or how large these defects may be. If you have significant right heart enlargement, that's just another marker of how significant your ASD size may be. This is some images on subcostal view. You can see there that the posterior inferior rim is adequate in this patient, as is the SVC rim, as you can see there on the right hand of the screen. This is the TE demonstrating a deficient aortic valve rim with both color and without color. This is just TE images measuring the atrial septal length and the size of the ASD at rest. Now, when you measure the atrial septal length, TE is a good modality, but I also recommend to use transthoracic echocardiogram. Often you'll get a larger length in some of the transthoracic echocardiogram views, so it's important to get a baseline measurement before you even enter the cardiac cath lab. This is again a TE showing the SVC, IVC rim there. Now with stop flow, you can see this is just a balloon size of the defect. I always use stop flow. I do recommend that because every now and then you may think that there's one ASD, but actually cross a fenestration. The stop flow technique also gives you an idea not just of the size of the defect, but the configuration of the defect. So it's an invaluable tool when you are embarking on these procedures. Here's the stop flow being assessed by TEE, and we measure the outer to outer on the balloon in multiple planes. Now here is deployment of a 32 millimeter device. Now remember, with the GORE Septal Occluder, the device was available only up to 30 millimeters. So this is just an example showing how this has really extended our reach and expanded our armamentarium when closing these ASDs. So you can see here on this fluoroscopic image, the device is being deployed by deploying the left atrial side of the device. And what you've noticed is while I am deploying the device, I'll show this here again. If you notice that you can pull back the delivery catheter as you push out the left atrial side of the device. If you're worried you're too close to the appendage or roof of the heart or surrounding left atrial wall, you can pull back the device gently while deploying the left atrial side. And you can see there the left atrial side of the device is coming out, and it forms this cone-shaped device, and that's when you meet a hard stop on the slider. So that's when you know that you have actually deployed the left atrial side of the device. This is what it's going to look like on TE. So this is going to be very different for your echo colleagues if they are not used to this device. It's very different from the GORE Septal Occluder. The device does not come out flat like the GORE Septal Occluder or the GSOs, as we call, would come out. So you can see here that cone-shaped configuration. So it will take some getting used to. You can see here that the device is being pulled back. You can see here on the left hand of the screen, this is that left atrial side of the device being deployed in the LA. This is when I brought it back to sort of engage the atrial septum. And then you can see here on the far right hand of the screen, the device has been brought back where that central portion, or waist, if you will, has been now deployed within the ASD. And again, you feel that with a tactile sense on the slider when you meet a hard stop. This is then, we're pulling back to the atrial septum. You want to pull back a little bit to engage that atrial septum. What you notice there on the right hand of the screen is I like the lateral view because you want the device or the delivery system to look a little bit posterior, not straight up when you're initially deploying the device. So you want to sort of follow the curve. You can see there the natural curve of the atrial septum so that the delivery catheter is directly perpendicular to that atrial septum and not parallel to the atrial septum. This is just a cartoon. These are some images by Adam Strobel from GORE, who was very kind to work on these illustrations, and with others' help. You can see here that this is a straightforward ASD being deployed using the, ASD occluder device being deployed in an ASD with good rims. However, if you have a deficient anterior superior rim, sometimes that device can slip through, as depicted in this series of illustrations. If you notice and recall from the beginning of the presentation, the handle and the slider is actually on top of the device. So most of the time, that's how you're going to actually deploy the device out in straightforward defects, with that slider really pointed up towards 12 o'clock. However, if you have a challenging ASD, particularly with a deficient aortic rim or a deficient SVC rim, you may want to actually rotate this handle clockwise, similar to what we would do with the GORE septal occluder device as well. And by doing so, you are able to catch that SVC and aortic rim. And you can see here in this case, this is that same case. Once we got the device in good position, you can see here that the device has been rotated clockwise to allow for that SVC and aortic rim to be captured. Here, this is just a TE image in the short axis view showing that the left atrial side of the device and the right atrial side of the device has grabbed that atrial septum that on either side of the aortic rim. And then the device is locked. And again, you can see here, once the device is locked by pulling back on the slide, let's see here, right there, you can see here that there's significant shift in the device once you lock the device with the handle. Now, this is a more dramatic shift in the device being depicted, and I'll stay on this slide just for a few minutes. Again, I just want to really emphasize this point. I know I've already emphasized it before, but you can see here that the device almost looks perpendicular to the defect. It's almost at 12 o'clock there. So there's this was a relatively large defect, I would say, for a small child, you know, deficient rim, so little challenging to get it in place, but with rotation, we were able to get it there. But what that means is that the septum, it may be hard to see, but there's septum right there in between the two sides of the device. The device is really perpendicular to the defect. There was no significant shunt, a little bit of shunt when evaluated by TE, but I was quite confident by assessing with my TE colleagues in multiple views that we had indeed grabbed all the necessary rims. So if you are happy that you have grabbed the rims, don't be alarmed by this image. In fact, go ahead and lock the device. The nice thing about this device is it can still be retrieved with the safety cord. If for some reason we were actually wrong and we had not grabbed the rims, or there was a shift in the device when we locked the device can safely be retrieved through the through the delivery catheter with the retrieval cord. So again, this is just a nice image of showing extreme shift once you've locked the device. And again, it has actually shifted into a much more favorable position after the device was locked. Once the device is locked, then the retrieval cord is removed from the handle by popping that red knob off and then removing the retrieval cord. You can see there how it looks fluoroscopically, and then you can see there the catheter moves away from the device. This is how the device looks like now after the retrieval cord has been removed and the device has been locked, retrieval cord removed. There's the short axis view. Here's the 4-chamber view. And this is the bicaval view. This is the view that showed that extreme movement or shift in the device into a favorable position. And you can see here that the SVC rim has been captured. I'll let that play. You can see here, this is the SVC rim. And to the left of the screen, you can see here my echo colleagues, Dr. Pignatelli sweeping. You can see there that the posterior inferior rim has been captured nicely between the two discs of the device. These are similar projections to what I've shown before. You can see that ariocaudal projection on the left hand of the screen and that eleocranial projection on the right hand of the screen showing very nice splay of the device. And that's really what you want to see. That's what it looks like in the AP cranial projection. I just want to go over some imaging tips with the device. I think all rims are important for all devices when we implant them, but particularly evaluating the posterior inferior rim is very important. You can see here in this image, you really sometimes can struggle with TE to look at that posterior inferior rim. And you can see here, it's really hard to see in this projection with the echo probe, really can't evaluate that posterior inferior or IVC rim effectively. So what is important to do, and this is something that our echo colleagues have been doing, is to really advance the probe down and flex towards the device, and you can get right up underneath there. And you can notice that this is that same patient. And what I want to show you is you can see here that posterior inferior rim where my cursor is on the left of the screen, and you can see that the device has grabbed it both on the left atrial side and right atrial side, and that was not visible before until we actually advanced the probe and got right underneath the device by flexing that device. So this is a very important maneuver. I would also say that if you have any doubts about that posterior inferior rim, fluoroscopy is important, but you could also use intracardiac echo, which is a very nice modality for evaluating the posterior inferior rim. And I only wanted to spend a little time on this just because it's so important to have that splay of the device, not just anterior superiorly, but posteriorly and inferiorly on your fluoroscopic image. So I just want to illustrate how a device can be retrieved with the retrieval cord still in place. So this is a 60-year-old patient with a large secundum ASD. Her twin had a similar defect. She weighed 54 kilograms, quite a large defect by stop flow diameter, very large shunt, as you can see. It's just a stop flow showing the device, the balloon size by stop flow diameter by using the stop flow technique. You can see here we were implanting a 48 millimeter device, but the device was not aligned to my liking. And you can see here the device being removed. Again, we have the retrieval cord still attached, and we are using the delivery catheter, and it's very easy to, once you just loosen that control catheter, you can actually just bring that device in using the retrieval cord quite easily. And you can see here on the AP and the lateral projection that the last bit of the device has been pulled in. What about the rare occurrence of device embolization? And as you noted in the assured trial for the GORE CardioForm ASD Occluder device, for the pivotal trial, there was one device embolization that I mentioned. It's rare, but nevertheless, one should understand some of the important retrieval steps. So this is an 18-year-old weighing 50 kilograms. The stop flow diameter was 23 millimeters. This patient had a QPQS of 2.3:1. So quite a large secundum ASD. This is a stop flow diameter being measured on fluoroscopy. You can see here that the rims were being assessed. What it's important to see is you can be fooled. You can look here on the left hand of the screen, the defect looks quite large, whereas on the right hand of the screen, at least in that plane, it's very hard to see the defects. So these ASDs are not always circular. In fact, they're not. They're more often than not circular. And so it's very important to assess these rims in all different planes. So 44 millimeter device was implanted. In this patient, there was inadequate IVC and posterior rim evaluation. Again, that's one of the points that I made in some of the previous slides. You can't really see there very well the posterior inferior rim, and the device did embolize to the PA. Now, if you do encounter such an occurrence, it's important not to obviously panic. These GORE devices, one of the nice things about them is even in this rare instance, they're fairly easy to retrieve. They're very soft and soft enough to retrieve, yet rigid enough to close large size defects. So if the device is obstructing flow in the MPA, it's important to push it out to one of the PAs, so at least you can maintain cardiac output through the other pulmonary artery. In this particular patient, an 18 French long sheath was used and the device was snared. You can snare the pin of the device. You can actually snare any portion of the device, but it's advisable to snare the pin of the device. And then you can see here that the device was retrieved successfully in the main pulmonary artery. There was no damage to the patient's pulmonary valve or tricuspid valve. The sheath you can see there is distal to the tricuspid valve. Finally, I'm just going to go over wireframe fractures. And this is just an example of a patient you can see here who underwent implantation of a large GORE CardioForm ASD Occluder device. You can see there that there are some fractures in the device. But what does that really mean clinically? Remember, this device it combines unique materials and it provides a soft and conformable device configuration for these ASDs. I'm just going to skip over this in the interest of time. I just want to show that in the assured clinical study, which I went over, 35% of patients had wireframe fractures. However, they were not associated with embolization, perforations to cardiac structures, cardiac tissue erosion, device fragmentation, or residual shunting. This is just an image showing where these wireframe fractures can occur. So they can occur at the spoke, the turn, the perimeter, or the waist of the device. And you can see here in the Assured pivotal trial, most of the patient fractures occurred in the spoke of the device, which was actually a good thing. There were very few that occurred at the spoke. And obviously that would be closer to surrounding tissue. So most of the fractures did occur near the spoke of the device. Again, the risk factors for wireframe fractures, if you were more than 18 years of age, that was associated with higher risk of fractures, and a device size group, larger devices and devices that were oversized were associated with wireframe fractures. This is just an image showing the fractures by size of the device. In general, the larger sizes devices do have a higher did have a higher rate of wireframe fractures. But again, if you look at not just the GORE CardioForm ASD Occluder device, but even the GSO device, this really translates into very minimal sequelae. In the GORE CardioForm Septal Occluder device, when we look at those, more than 45,000 have been sold, and the incidence rate is 0.004% of a clinical sequelae, and only 2 reported cases reported with that device, and 0 to date have been reported with the GORE CardioForm ASD Occluder device. You can see an animal picture just showing when a fracture does occur, showing endothelialization over that. The EPTFE is occlusive and covers that as well, in addition to that endothelialization. This is the wireframe fracture rates from the, looking at the device-related serious adverse events through the PFO GORE Reduced clinical study, the IDE study for the GORE CardioForm Septal Occluder, and the GORE Assured trial as well. And again, the most important thing to see here is there's 0 cases of reported clinical sequelae with any of these wireframe fractures. So this is just a series of images showing that a patient had a device implanted, and GORE ASD Occluder device with multiple fractures. However, there was no clinical sequelae, no leaks seen in any of these projections. So in summary, I think that the GORE CardioForm ASD Occluder device is safe and effective for closure of secundum ASDs due to its unique features, its expanded size range and safety profile. The GORE CardioForm ASD Occluder expands the options for secundum ASD closure for interventional cardiologists. Now, for those of you who have used the device, and for those of you who have not used the device, it's sometimes brought up about the different steps that are involved. The device is very intuitive. In fact, I remember going to my daughter's school, and when she was in 5th grade, she and her classmates were able to implant the GORE CardioForm the GSO device very easily. They learned it very quickly. They were having a lot of fun. My daughter, who is now 14, taught my 7-year-old. This is my 7-year-old using one of the previous generation GORE devices. It is intuitive, and it is definitely very advantageous, particularly with regards to its safety profile and effectiveness for closing these ASDs. Lots of people to thank, my friends and colleagues at GORE, and really would like to thank GORE for all that they do for our patients and their families. Thank you very much.
Thank you so much, Dr. Qureshi. Great presentation, really appreciate it. We do have a few questions that have come in regarding your presentation that I'd like to go ahead and ask you at this time, if you wouldn't mind answering. Absolutely. So the first question is the technique for deficient rim similar to that used for Amplats or device? Explain if different.
Yeah, I think that the technique is similar in that the understanding of the anatomy is obviously similar. You have to understand the anatomy in 3 dimensions. So the second case that I showed, where we were actually rotating the handle of the device to catch that SVC and aortic rim, is a similar sort of technique where you're really just trying to capture those deficient aortic rims by rotating the device and aligning it to the septum.
Great, thank you. Another question here is, do you think sometimes with large defects, it becomes a hard maneuver to take position of the sizing balloon and its measure not results in accuracy?
Very good question. I think yes. I think if you have a large defect, it can be quite challenging to size the defect. And in general, I always still size these defects. I think it does require some time. Sometimes you may require a long sheath to stabilize your balloon, or just a little bit more deployment in the LA while pulling back, being mindful of surrounding structures. But if you do have any residual flow around the device, around the balloon, you know that you're not adequately stopping flow. So it can be challenging with large defects, but there are ways around it. I think using a longer balloon, as long a balloon as possible, is really helpful if there's enough room in the patient's heart to size the defect.
Great, thank you. Once you get to the 44mm device, is it more difficult to deploy with the absence of retroaortic rims? Significant rotation with the catheter still seems to bring the device back perpendicular. Does the size of the LA affect this?
And by the size, did you mean small size of the LA? Am I understanding that question?
It doesn't specify.
I'll try to answer the question to the best of my
yes, small LA, yep.
Yeah, I think that's a fantastic question. And if you recall on the second case that I presented, it was a small child. It wasn't a very large defect, up to 18mm, but nevertheless, it was a deficient aortic valve rim. So to answer your question, yes, once you reach the larger size defect requiring a larger size device, it is more challenging to align the device properly. So I think when you start these cases, it's nice to actually start with quote unquote more straightforward defects, just to get an idea of how to use the device first. But you're right, using larger devices in larger defects can add a layer of complexity when trying to align the device, but that can be done by some of the techniques that I demonstrated and some of them that we'll demonstrate in a webinar down the road. If the LA is small and you are using a large device, it can be done quite safely, and we've done that in a number of patients. The trick there is to rather than having your delivery catheter in the LA and just pushing the LA side of the device all the way out, is doing it in series where you push a little bit of the device out, you can pull back the sheath, you can even pull back the sheath close to the defect while you are deploying the LA side of the device. And so what you're trying to do in that instance is really cheat, if you will, on the LA side by trying to bring the delivery system back towards the ASD that allows you to push more of the left atrial side of the device out.
Great, thank you. Given the high rate of frame fracture in the larger ASD devices, what are your recommendations for ongoing fluoroscopic and echocardiographic follow-up?
I think that's a good question. Currently, there are no hard recommendations for that. Obviously, for the trial, we had fluoroscopic evaluation at 6 months. And there will be more data 3 years in these patients down the road from the continued access trial. There's no hard recommendation. I think that, fortunately, we've not seen any clinical sequelae for this. I often get asked that by the patients also. And if there are frame fractures, we are not following them any differently than any other patient, as long as they have not had any clinically significant arrhythmias, which again are very low rate. And again, the fractures are not associated with residual defects. So we do not recommend changing our practice solely based on the occurrence of frame fractures.
For retrieval, do you have any recommendations about choice of sheath size? And does it make any difference whether you grab the pin at the locking loop or the opposite pin?
Yeah, so in general, obviously, you want to use the same size sheath or larger, usually a larger size sheath, as large as you can accommodate. With that 44 millimeter device that embolized, an 18 millimeter sheath was used, but you can retrieve it in smaller size sheets as well. You want to be a little larger than the sheath that you have deployed. In general, you want to, it's nice to grab the right atrial side of the pin, and you want to grab it sort of coaxial, where it can come into into your long sheath easily. The devices are so soft that if you need to grab the device to get it out of a position and just get it somewhere where you can work with it more, for example, let's say it's in the right atrium away from the tricuspid valve, you can grab any portion of the device and bring it to the IVC. That gives you a little bit more safety net to work with the device. So you can grab either pin. It's recommended that if you can, though, grab that right atrial side of the device, coaxial, where you can pull it in, and use a larger sheath, at least 2 French larger. Sometimes that may not work depending on the orientation of the device, but if you bring it into a location where you can actually use a different size sheath, for example, the IVC, or get it more coaxial, then you can do that as well.
Great, thank you. Is there a difference in results if you separate the ICE results and the TEE results? And I'm not sure if you...
the only, if I'm understanding the question about maybe deployment or residual shunts, the only comment I would have about that is ICE is very good for evaluating that posterior inferior rim. So for a large defect, and if you can't see that posterior inferior rim with TEE, then ICE is recommended. You know, if you're doing these procedures with conscious sedations, many adult labs, some pediatric hospitals in older patients, then ICE is very reasonable to do if you're doing it to avoid general anesthesia.
Great, thank you. Last question we have here is, how many attempts of deployment before you would get a new device? And I will note that per the IFU states up to 3 device attempts.
Yeah, I would just echo that. I think up to 3 attempts. I will only add, the only thing I would add to that, Tom, is that with each attempt, it gets increasingly difficult. So if you are having, if you're faced with a challenging defect, really try to understand it as much as you can before. But even on those, that 3rd attempt, it's not infrequent that it becomes a little bit harder to deploy the device. And that's why, as you say, Tom, no more than 3 per the IFU.
And while everybody's answering those poll questions, I just want to thank Dr. Qureshi again for such a great presentation in the extenuating circumstances that you've had to face there in Houston. We really do appreciate you putting this presentation together, and thank you again. And hopefully you're staying safe out there in Houston, and have some power and heat as well. So.
Yes, thank you all, and please everybody stay safe.